Okay, good morning, everyone. I think we'll get started. It looks like right at 8:30. Thanks so much for coming out this morning. It's always a pleasure to be here and to talk to really engaged groups. So I'm going to be talking about electronic health records and big data, and it's based on a book that I published a couple of years ago, or a year and a half ago, by the same name. It deals with the law and policy of electronic health records and medical big data. And these are really important contemporary issues, I think. I will start by talking about electronic health records and then finish up by talking about big data, which is often arising from electronic health records. So everyone thinks of electronic health records as really contemporary, cutting-edge technology, but I actually found some evidence that it's been around in one form or another for as long as 50 years. So let's see if I can get the video to work. Always a challenge. I am not finding the mouse. Oh, there it is.
We have here a joint study undertaken in 1961 with the International Business Machine, determining if it was possible to eliminate the paperwork, or at least part of the paperwork, which has burdened the nurses and doctors in hospitals for these many years. In 1964, 15 input and output terminals were installed throughout the hospital. 7 of these were put at the nurses' stations and the balance at the ancillary departments. These terminals have many purposes, and the orders for medications and tests as they are generated at that floor and as written by the doctors and nurses. This information, in turn, is sent to the central computer and is then related back to the ancillary department involved. Now, so far as drugs are concerned and orders of this kind, the nurse at the desk is reminded at a specific time of day when she should give the drug and in what amounts. In spite of the relative short time that we have been working with the terminals, we now can see certain advantages that are taking place. It is going to be possible to relieve the nurses and the doctors of some of their paperwork. It is going to be possible to have correlation of diseases which we have not had before. And it is going to be possible to eliminate errors in medications and in tests of this kind, which would be harmful to the patient.
Okay, so obviously this was before HIPAA. We saw patient names on a video that anyone can look at on YouTube. But he makes a prediction that this will really take off, and that didn't actually happen for a very long time. It didn't happen until this century. And so the transition to electronic health records, how many people have seen computers in their doctor's offices? Okay, it's omnipresent now. But this transition really didn't start occurring very seriously until about 2004, where President Bush made it a priority for the federal government. And he said that he wanted all Americans' health records to be computerized by 2014, so he gave it 10 years. And it still was very, very slow. Not much was happening until 2009, when President Obama, in his stimulus plan, everyone thinks this is part of Obamacare, the healthcare reform. It's not. It was part of the stimulus plan. But the stimulus plan included the HITECH Act, which set aside $27 billion for the promotion of health information technology. So doctors and healthcare providers, hospitals, clinics that adopted electronic health records could actually get money to support them. And so that's why they started doing it, and now we see computers everywhere. So let's talk a little bit about what electronic health record systems are. So first of all, they are record systems. So it's very traditional. Clinicians input information into these records, and doctors take a look at them when they need information. So they replace the paper records that we were all familiar with. But electronic health, so messages pop up on the doctor's screen saying, remember it's time for the patient's annual mammogram, or this patient is allergic to penicillin. And so those kinds of alerts and reminders can be life-saving, and it's also called decision support. It really can help doctors make their medical decisions. They also enable computerized physician order entry. So doctors can send orders directly to the lab or to the pharmacy, and you no longer have to run around with those pieces of paper that had a lot of illegible handwriting on them. Secure messaging. How many people have communicated electronically with their doctors? Okay, some, but I don't know if the majority. But this is a new feature. You can use the computer system, MyChart or Follow My Health, to send your doctor messages electronically. You don't have to call and hope that somebody will convey a message to him. And you can get, hopefully, answers quickly from your doctor for your inquiries. And so a lot of patients really like this feature. Personal health records, PHRs. How many people have logged on to MyChart or Follow My Health to look at information? Okay, about the same number. So this allows you to log on to your account and to see test results right away, or to see appointment schedules, or figure out what clinical information they have about you. So another nifty feature that a lot of patients like. Data analysis tools. So doctors can actually look at the records and analyze them. So let's say some drug is recalled because there's some big problem with it. Your doctor can do a search through his records or her records and quickly figure out who is taking this drug, who needs the information, and then convey the information electronically. Stop taking this drug, it's really bad for you. And finally, interoperability. So this was a great hope that has not actually materialized yet. So the idea is that all electronic health record systems would operate smoothly together. And so if you went to a different system for a second opinion, you went to the Cleveland Clinic for a second opinion after you got a diagnosis from UH, the doctors at the Cleveland Clinic, with proper authorization, could log into your account at UH and see all the information about you, all the tests that were done, all your medical history, and so on. Or if you went to Florida for the winter, or if you got to the emergency room and you were unconscious or confused, they wouldn't have to operate in a vacuum. They could log onto your medical record and know your drug allergies, your medical history, and so on. And that would be extremely helpful. Not happening right now. UH and Cleveland Clinic have completely different electronic health record systems that are not interoperable. And that's a big problem, and that's throughout the United States. So interoperability, you might see that word. It's a big focus for the government now. This is an area that they feel they really, really need to work on. So why have we undertaken this transition? What are the benefits? Well, One reason that a lot of people talked about is every other industry had computerized, and the medical industry was way behind, so it was just time when we reached the new millennium. But there are also significant benefits. So one hope is that it will reduce medical errors, right? We have computers, you're not going to have illegible handwriting, you're not going to have mistakes, you're going to have all these alerts and reminders keeping doctors on track, and so there'll be fewer errors, and therefore we can improve patient safety. They also facilitate communication. They facilitate communication among medical team members because they can all look at the computer and see the same thing. If we had interoperability, it would increase communication among physicians throughout the United States, and it increases communication between physicians and their patients. And better communication should lead to better outcomes. And it should also lead to happier patients. So patients who feel they're communicating well with the doctor and that the doctor is always accessible to them are happier. They are less likely to sue even if the treatment outcomes are suboptimal. And by contrast, patients, we've seen this in study after study, patients who are unhappy with their relationship with their doctor are more likely to sue. And a lot of advocates touted huge cost savings. So optimistic estimates that I've seen were $77 billion per year or $81 billion per year. Why? Well, first of all, if we reduce errors, we reduce the need to treat people for medical errors, so fewer hospitalizations, fewer complications. Also, if you have interoperability, you would have less duplication of tests. So doctors could just see all the tests that were done to you. They wouldn't have to redo tests, and that would save a lot of money. And finally, you would have administrative savings because you wouldn't have to hire people to do filing, to type up notes, to do mailings, and so on. It would all be done by clinicians on the computer. Now, these cost savings have not materialized yet, but some people who are optimistic say, well, that's because we're still in transition, people are struggling, people aren't expert at handling this technology, and so eventually we will start seeing big cost savings. So one can hope. What we are seeing, however, unfortunately, is that doctors are pretty unhappy with their electronic health record systems. Has anybody heard this from any doctors? Okay, well, a few, but I'm telling you. So there are a lot of shortcomings, there are a lot of problems with these that doctors are really decrying. So let's talk about some of them. First of all, there is information overload. So when you had paper records, some of the files were pretty thick, but they had a nice summary sheet in the front, and they had tabs that doctors could flip through, remember that? And they were easy to navigate. And now the electronic health records, it's hundreds of screens, they all look the same. It's very hard for doctors to navigate them and to find the details that they need at their fingertips. And so another feature of these systems that creates problems in this regard is copy and paste. So to save time, you can copy narrative from a prior visit and insert it into the current visit. And that saves time, but it makes these records incredibly long. And it also can introduce errors into the record, because if you're copying and pasting but you're not updating, you're making mistakes. So there are all sorts of anecdotes, like the notes every day say this is the 2nd day of antibiotics in the hospital, when really it's the 7th day, because they just copied and pasted and forgot to update. So that's one way you increase errors. Decision support. It can be life-saving if it warns doctors about serious side effects or serious allergies, but it's overwhelming to doctors. The vendors put in every possible alert and reminder in order to avoid liability, and so doctors get alerts about things that are trivial, that almost never happen, or things that clearly don't apply to the patient at hand. And they say they spend an enormous amount of time just dealing with all of these decision support messages that they get, dozens and dozens per day. Some of them turn the whole feature off, but then they're going to miss critical alerts and reminders. Software defects and computer shutdowns. So we're all familiar with that. These kinds of things mess up my footnotes in books and articles. They probably mess up your briefs. But that's frustrating, but not life-threatening. In a clinical setting, it can get life-threatening. And so there are stories, for example, where the doctor put in the patient's weight in order to calculate the appropriate dosage, and he was, of course, thinking pounds. But the computer somehow was set at kilograms, and so the computer thought the weight was in kilograms, and you get completely a wrong dosage, because pounds and kilograms are really different. Computer shutdowns also happen in hospitals, and so my husband and I years ago went to visit there's some seats in the front here. Went to visit a friend who had given birth by C-section, and we came in all cheerful. How are you? Congratulations. And she said, terrible. I can't get any pain meds because they can't access the computer. Without the computer, they won't give me pain meds. And of course, pain meds is one thing. Sometimes it's even more serious than that. Other concerns. So the idea was to reduce errors, but we are finding that there are a lot of errors even in electronic health records. So we have solved the problem of illegible handwriting, and that is a blessing. But all sorts of new opportunities. Clinicians are typing quickly, and so they can invert numbers or misspell words in ways that are misleading. There's all sorts of choosing items from drop-down menus. It's really easy to select the wrong item from a drop-down menu. Clicking and unclicking boxes, very easy to do that incorrectly. And so these are rife with mistakes. They've done some studies of different groups of electronic health records, and they're finding error rates in the double digits, and that's really discouraging. So if you do log on to your personal health record, MyChart, University Hospitals, Follow My Health, look at the clinical information that they list for you. I know I have some mistakes in mine, and it would be useful for you to figure out if you have mistakes in yours. You can ask for them to change it. Hopefully they do, not always, but errors are really not uncommon. Time constraints and system demands. So electronic health records take doctors a lot more time to deal with than paper records did. In the good old days, they used to be able to jot down notes at their discretion or dictate some notes and have a secretary type it up. Now they have to do whatever the computer demands of them, and the demands are rigorous. And so doctors constantly tell me, I used to come home for dinner at 6:30. Now I come home at 9 because I have to spend so many hours, perhaps as much as half of their time, half of their working time, on documentation, on dealing with the computer. Or they come home at 6:30 and then they have to spend hours afterwards, not playing with their children, but playing with the computer. There's actually a new term of art that I learned, pajama time. If you say pajama time to your doctor, they will say, oh, yes, I have that. I work with the computer for hours after dinner. And they are very frustrated with that, exhausted, demoralized, and unhappy. Also, there is some rigidity in this system. So if you want to order a medication, you have to choose from a drop-down menu what condition you are ordering it for. But sometimes you're being creative and you're ordering it off-label and it doesn't fit one of the choices that the computer is giving you. And so you either have to spend a whole lot of time overriding and explaining to the computer why you are doing something different, or let's say you want to give a different dosage because this is a particularly sensitive patient or younger patient or whatever. Overriding takes a lot of time. Or you just pick something from the drop-down menu so that it will let you order that medication and won't bother you, but then you've just introduced an error into the record because now it's going to look like you have a condition that you don't. So inflexibility is a problem that people talk about also. And privacy. Once you computerized records, those records become vulnerable to hacking, to misplaced or stolen laptops or memory sticks or other equipment, and to intentional or accidental disclosure. And so I've been consulted on a few cases. I'll tell you a couple of stories. In one case, there was someone famous in the hospital, and an employee sent some information to the media. It's very easy now. You can do it discreetly at your desk. Just press send. You used to have to actually take files to the copy room and copy them in front of everyone. It's much easier. A second case is a little bit funny, not for the people involved, but this was a plastic surgeon who wanted to post on her website before and after photos of breast enhancement surgeries to advertise her wonderful services. And she got patients to agree. She promised this would be de-identified, and they signed consent forms, and everything was great. She built a very nice website. And then one day, one of the patient's husbands decided to Google her because she was looking for a new job, and he wanted to figure out what would the employer see when they Googled her, because employers Google nowadays, in case people weren't aware. So he does this Google search, and up pop her breasts before and after. And he was horrified. And why did that happen? The physician didn't post, the name of the patient on the photo, but she had saved these files under the real names of the patients. And so Google recognized that, and I think in teeny tiny print at the bottom of the photo, it said janesmith.doc or whatever. And so these were for public consumption, everybody's breasts. And so the doctor's lawyer called me up and said, well, of course, HIPAA provides a defense, right, for very innocent mistakes. And I said, no, my advice is call them up, settle tomorrow. So, lots and lots of privacy breaches. Now, the other thing physicians complain about is that electronic health record systems disrupt the patient-physician relationship. Has anyone like me sat in a doctor's office and instead of the doctor talking to you about what hurts, the doctor is cursing the computer? Okay, yes? So that's unpleasant, and it's very common, and it's captured beautifully by this picture that a 7-year-old drew describing her doctor's visit. And I don't know how clear this is, but you can see her on the examination table, and mommy and siblings, everybody's around her. She's interacting with them. Where is the doctor? At the other side of the room, bent over a computer, not talking to anyone. And that is her impression of her doctor's visit. So this summer, I worked on an article about physician burnout. If you're interested, it will be coming out in January, supposedly, in the Yale Journal of Health Policy, Law, and Ethics. And it turns out they've done studies. As of 2014, 54% of physicians were found to suffer from burnout. We have very unhappy physicians. Burnout is defined as emotional exhaustion, depersonalization, not being able to see the patients as human beings that you really care about, and dissatisfaction with work. And when they do these studies, the physicians identify electronic health record systems and the regulations that govern them, that tell physicians what they have to do with these electronic health record systems. These are always listed as significant contributors to burnout, so they are big culprits. And so one study, for example, looked at the emergency room. Now, in the emergency room, we hope that doctors are focused almost exclusively on patients because many of them are coming in terrible pain, in critical condition. And yet, in a 10-hour shift, doctors had to go through 4,000 clicks, 400 clicks per hour. That is a whole lot of computer time, even in the emergency room. So, what are the litigation concerns? Well, I've suggested throughout already that a significant litigation concern is more problems, more malpractice, more liability because more opportunities for error, less time for doctors to spend with patients, more frustration with the computer. And so will there be increased litigation and liability? Now, so far, I am not seeing a lot of cases, I do see a few, where the computer is explicitly blamed as part of the problem. But I think that's because plaintiffs' attorneys are not really attuned yet to this technology, don't know to focus on it. Chances are, if something went wrong, the computer played some role because the computer manages most aspects of patient care now. Interesting thought, will use of decision support be a defense? Will doctors start saying, well, I followed orders, just following orders, the computer's orders, but it gave me alerts and reminders and I followed them, and so I should not be at fault. Will electronic health record system vendors be named as defendants commonly? It's not a bad idea. They are deep pockets, right? Maybe they'll settle really quickly. Again, I'm not seeing this yet very commonly, but I would think that that would be an emerging trend. Has anybody worked with cases that involve EHR vendors? No one here. Well, it's not a bad idea. The downside is that this will make cases more complicated, more expensive, larger. It is hard to prove failures of complex electronic health record systems. The problem could be in one line of code out of millions. But this is a decent way to settle your case with someone that has a lot of money. And so I think plaintiffs' attorneys who've read the book, heard me talk, are thinking about electronic health records, may start going after vendors. Now, has anyone worked with electronic health records in discovery? No one here. Okay. Well, they make discovery sort of difficult. So electronic health records are live records, right? And so if you get it produced in a printout or a disk or whatever, it's not what the doctor saw at the time. It's not like taking a few pages out of the record. What the doctor saw at the time was different because since then, tons of stuff has been inputted. And it's not what your opponent will see at a different time when they're looking at the record. And so it's misleading in some ways, and it's also incomplete because the records have all sorts of hyperlinks and ways to jump around, and when it's produced, it's not the same. You can't use the hyperlinks, etc. Very important issue is metadata. Metadata is data about data. So it's Who looked at the record? For how long? How often? Did they change something? That is not in the record itself. That is metadata that you have to get separately. And so some attorneys don't know to ask for that. And that could be the whole key to your case, right? We used to be able to see whiteout and some scratching on paper records. You don't see that anymore. It's all in the metadata. And some judges don't understand it. So even if attorneys ask for that, the judges will say, well, they produced the record. Stop being so greedy. You don't need any more. And that can be devastating. So everyone needs to learn about metadata. And then just some general regulatory questions. Can the law keep up with technology? And so there are constant emerging privacy threats. How do we provide healthcare providers with adequate guidance? How do we make regulations that really can safeguard the privacy of this technology? So about a year and a half ago, we all of a sudden had a new phenomenon, ransomware. No one had anticipated this. No one had heard of it before. And so attackers would encrypt electronic health records so no one could access them, and then they would demand ransom and promise they would give you a decryption key if you paid a lot of money. And then if you did pay the money, they either would or wouldn't give you a decryption key. You had no control over it. Sometimes they would take the money and run. And this absolutely paralyzed the national health system in Great Britain and caused big problems here in the United States. Well, how do you protect against that? How do you teach people how to react to that, how to prevent that? It's very hard for HHS, the Department of Health and Human Services, and for the regulatory system to keep up with these kinds of sophisticated threats. And quality control. Right? People think, oh, it's just a computer, so we don't need that much testing. But we went through it. It is so much more than just a record system. It manages every aspect, pretty much, of patient care. And a shutdown can be devastating. So how do we achieve quality control? There is a certification system now for electronic health record systems, but it's minimal. It's skeletal. It involves 1 day of testing, and the vendors get the testing scenarios in advance. It's really very unimpressive. It is so much less than we do for drugs and devices that we test very thoroughly. And that doesn't make sense to me because these are just so important for patient care. So I've written a couple of papers saying, we actually need to test these in real clinical settings over a period of time to see how actual users will interact with them, to make it easy for them so they don't have to have as much pajama time and burnout and all the rest of it. There could be some litigation advantages, though. Right? If we have more information, hopefully we're getting more evidence of what actually happened during medical encounters, and we might be able more easily to discover the truth. And the truth is good in litigation, presumably, at least for one of the sides. And if we improve our search capacities, we could make discovery easier instead of sitting with boxes and boxes and boxes of documents. One of my first jobs was at a law firm, and I worked on the Exxon Valdez oil spill case. Remember that? We had airplane hangars full of boxes with documents. And so having everything computerized and searchable would have been great. And so if we can search through these records electronically, that could save a lot of time. You could do a search and everything you need would be at your fingertips. All right, so I think I've talked enough about electronic health records for now, so let's switch to the really exciting topic of big data. So one hope is that all of these electronic health records will enable us to do a whole lot of research, right? You no longer have paper records that are locked in a file cabinet. It's all computerized, and so you can build a huge database with millions of records for patients all over the country with diverse attributes, diverse demographics, and really figure out what is going on. What happens when people get treatment in a real clinical setting by real doctors, not in the controlled setting of clinical trials that are done before a drug is approved. And we could perhaps, using these huge data resources, have large-scale observational trials and studies that will fill knowledge gaps and promote evidence-based medicine. And so we could learn a lot more about what treatments work well for people, what adverse reactions they really get when the doctors prescribe medications, and have much better health outcomes. And so we have a whole lot of government and private industry databases that are being created for this purpose. The government, for example, has this All of Us project going where they are trying to collect 1 million records and put it in a huge database that will be used for research. And private industry is trying to do the same thing, and they will sell records to researchers. But this can be really, really useful. So how do we define big data? It's not easy, apparently. So in 2014, Forbes had an article called 12 Big Data Definitions. What's yours? But a very elementary definition involves the 3 V's: volume, variety, and velocity. So big data is big volume collections of information. They are very large. And they are very diverse. There's a lot of variety. That's the whole point. Don't only have upper-class white males in your collection. Have a diverse patient population so that you can do good research. And velocity refers to how quickly they grow. So these are evolving databases that are constantly changing and growing, and more information is added to them. It's really important to understand, however, that health information is not limited to electronic health records. So this is where this talk gets scary. Health information is everywhere. People can get health information from numerous sources. A key one is purchasing records. When you buy stuff, people are watching, people are keeping track, and people are keeping records. And so there's a well-known article entitled "How Target Figured Out That a Teenage Girl Was Pregnant Before Her Father Did." So what happened? One day, Dad noticed that his daughter was getting a lot of advertisements from Target for baby goods, and he was horrified, and he ran to Target with the packet in his hand, and he demanded to speak to a manager, and he said, What are you doing? My innocent angel is going to get bad ideas. Stop sending her all this stuff. And the manager apologized and said he would look into it. And the next day he called up Dad and he said, I think you need to have a discussion with Innocent Angel because we're pretty sure she is pregnant. And sure enough, she was. And how did they figure that out? I don't think she bought a pregnancy test there, but she did buy prenatal vitamins and lotions with no scent. And through data mining of their purchasing records, they were able to figure out she's pregnant, and it's in their interest to figure those things out because then they can tailor their advertising materials to what people need and want. I did a sabbatical at the Centers for Disease Control and Prevention in 2007, and they had one of these E. coli outbreaks. And they were able very quickly to figure out that the culprit was Dole spinach. I hate spinach, so I was really glad that was it and not cookies or something. And so how did they do that? They took everybody's grocery loyalty cards and they scanned them, all the people who were hospitalized with this E. coli. they scanned them and they found that the one item they all had in common was Dole spinach, right? And so it's very useful not only for research, but also for public health purposes. They were able to stop this because they recalled all of Dole spinach. But of course, when they ran those grocery cards, they also saw everything else those people had purchased, right? And there are all sorts of studies that look at indicators of good health, indicators of bad health. So they understandably found that people who make purchases in bike shops are healthier than others, right? So if you ever are looking for a job or you want people to think you're healthy, you don't even have to buy a bike. Just go make a purchase in the bike shop and you'll pop up as really healthy. People who vote in midterm elections have been found to be healthier than others because at least before this year, I hope everybody votes this year, but before this year, the turnout was low and it was mostly people who were really engaged and interested in politics and had the leisure to follow it, and so those tend to be healthier people. So all kinds of indicators of good and bad health. Social media. People disclose all sorts of things on social media, and there are parties that are looking at that because your health information is very valuable to them. So for example, employers, all sorts of stories of employers looking at social media. My understanding is, I am not on Facebook, but my understanding is that employers ask employees, we want to be your friend on Facebook, and then they have access to everything. And so, for example, somebody had shoulder surgery and took a long medical leave, and then foolishly started posting photos of all the nice places he was visiting during the medical leave. And after the medical leave, he had no job left because they said, goodbye, continue taking those nice trips. Internet searches, right? How many of us do an internet search and then for weeks afterwards, messages pop up, advertisements, right, relating to that search you did for a destination or airline tickets or a store, clothing, whatever. And that is because Google is looking and keeping records and figures, oh, if you searched for this, you might want nice dresses. We'll start filling your screen with advertisements for nice dresses. And so if you search for symptoms, which a lot of us do, or diseases, they are paying attention to that as well. Credit scores, there's circumstances under which people can get your credit scores, and those are revealing about your health as well. So people with good credit scores tend to be healthier because they can afford follow-up care and therapy and to fill their prescriptions. People with bad credit scores, the opposite is true. Not as healthy, can't get follow-up care, can't fill prescriptions, and so on. And so that's a good source of health data. So the bottom line is there's an emerging industry of data brokers who collect data, organize it, sell it to interested third parties, and they have a lot of customers. By some accounts, there are hundreds of data brokers. So a really well-known one is Axiom. And on their website, they say they have data regarding all but a small percentage of U.S. households, and their information is used to make 12% of the nation's direct marketing sales. So if you wonder why you are getting advertisements that actually seem pretty well tailored to your needs and desires, it's because somebody bought data from Axiom probably. And about a year ago, I was speaking at a conference at Indiana University, and there was someone from Axiom speaking there too. And I asked her, I had read about this, I asked her, do you actually sell lists of people identified by name and the diseases that they have? And she hemmed and hawed and told me about their privacy policies and that privacy is their top priority and they would never compromise anyone's privacy. And then, yes, for the right amount of money, you can buy those lists of people by name with the diseases that they have. Spokeo is a people search engine that organizes white page listings, public records, and social network information into simple profiles to help you safely find and learn about people. So there you have it. That's just 2 out of hundreds. So what are the legal concerns? Well, I don't even need to say this. Privacy. Is there any privacy? There are now academic articles coming out. We're in a post-privacy age. Forget it. There is no privacy. People know about you. If you use the internet at all, if you buy anything at all, people know a whole lot about you. So do we still care about privacy? Is there any way to safeguard it? What do people know and not know? And why do we care about privacy? One reason is because of concern about discrimination. So if people have information about you, they might make decisions that are not in your best interest. Employers, lenders, others might deprive you of opportunities because they think you are sick or are going to get sick. So another paper I wrote a year or two ago is just about that. So I looked at our anti-discrimination laws, the Americans with Disabilities Act, other anti-discrimination laws, and I realized that they protect us against discrimination based on current disabilities, record of past disabilities, or if somebody wrongly thinks you are currently disabled. But they do not touch predictive data. And so if people are looking at all of these big data sources and they see your health habits are terrible, your eating habits are terrible, they can predict that you'll be sick in the future. And they can decide not to hire you based on that, right? Cleveland Clinic, I think, already won't hire smokers because they're afraid that those people will get sick, because you can always tell them to just smoke outside, not in the building, but they're worried about healthcare costs. And that kind of predictive information-based discrimination is not prohibited by law, unless it's genetic information. The Genetic Information Non-Discrimination Act does prohibit discrimination based on any genetic information, but it only reaches employers and health insurers, not lenders, marketers, life insurers, or anyone else. So I wrote an article saying I think we need to rethink this. I think the Americans with Disabilities Act and other acts need to address what is now very easily found, predictive health data. And maybe we don't want employers to be able to reject us because they think that in the future we will become sick based on health habits, eating habits, or whatever, or whether we vote in midterm elections, right? Whatever other information they have. And then, just interesting question, are we going to start seeing use of big data in litigation? There are such rich information sources. Are we going to start getting litigants saying, well, we purchased all this big data and we conclude X? What kind of conclusions are going to be found to be valid? What will be admissible? What will be used in litigation? It's a whole new world out there with lots of interesting questions. So I want to leave a little bit of time for Q&A. So I think I will stop here. The book is this, Electronic Health Records and Medical Big Data Law and Policy, Cambridge University Press, 2016. I think I included flyers in all of your folders. I am not selling it, but it's easily available on Amazon for a good price. It's paperback. So you can take a look at that. And if you're interested in this, we are going to have a great conference on April 5th. I am working on organizing that right now. It's called Electronic Health Records and Patient Safety, Legal Challenges and Solutions. It's a Friday, a full-day conference at the law school with lots of good, healthy food. And we'd love to see you there And now I'd love to have a bit of a discussion with some questions. Yes?
You say there's no more privacy. Now, what is the purpose of having all these HIPAA and privacy regulations? Isn't it kind of a sham?
Right. Well, HIPAA does protect your health records per se, so your doctor can't go and sell your records to marketers. So that is somewhat useful. But as I said, there are all these other data sources, and doctors can disclose de-identified records. HIPAA provides some guidance as to what information you remove to de-identify it, and then it can be disclosed with no regulatory constraints. And there are experts that say you can never de-identify thoroughly enough to prevent really motivated and skilled attackers from re-identifying some percentage of records. So it is very problematic and of concern. You have a follow-up, I think, where you have a microphone.
Really limiting my question. I'm sorry. I wasn't really limiting my question to HIPAA records. It's all these other records, bank records, financial records, personnel records, whatever, that if you have the right software and intelligence, you can get some people, the select few are the ones willing to pay. The rest of us are in the dark. So they're available. There's no privacy, but for some people, there's privacy, not for others. I don't know, something like that.
Yes, that is certainly an argument that is made, that if you have enough money and are sophisticated enough, you can obtain records. You can also have access to more technology that might safeguard your records. So there are ways on your own computer to secure data, but the vast majority of people do have a whole lot of their information floating out there and accessible.
Well, you also, the second question, I'll follow up, is you talked about predictive analysis for ADA purposes. Makes sense to me. But on the other hand, you have credit reports that make predictive data, predictive analysis based on status and so on all the time. So why distinguish ADA from decisions made based on a credit report, for example?
Right. So, well, first of all, for credit report, there are some constraints on the circumstances under which people can get that and how. And there is discussion in the anti-discrimination community about limiting their use because credit scores have a disparate impact on minorities, on people who aren't very healthy. And so there is concern about that. And I would say that we should prohibit discrimination based on that because it's the same as other predictive data. So you're right to point that out. So other questions? Yeah, Jeff.
Hi, two questions. One is, does anybody get it in terms of producing a clearly superior EHR system that's continually being improved? And secondly, who do you think will be spurring the innovations here? Do you think it should be the big United Health, big health insurers, or do you think it could come from the this health consortium, the Amazon new consortium producing their own health system?
So the innovations have to come from the vendors, really, but the vendors need to be working with all stakeholders. And that's a lot of the complaint is that the vendors sort of, in order to get the money from the stimulus plan, they rushed products out. They didn't work with clinicians. They didn't work with all of with the insurers, with all of the experts in order to try to make these products as good as possible and as usable as possible, because usability is the key. What was your first question?
Is there really a clearly superior
Oh.
product, or is there a system that really uses one that takes into account all these concerns?
Yeah, I mean, doctors, first of all, I'm probably not allowed to declare a system superior, probably conflict of interest or whatever, but clinicians really are complaining about most of them. These problems are sort of chronic, and and present everywhere. So there are ones that are more commercially successful, but I don't know of one where doctors have told me, this is it, I have no problem. The AMA has some statements, and it has some statements about burnout and so on, but it has not blessed a particular EHR as superior to others. So lots of room for improvement in all of them. And part of it is that this is overwhelming for the vendors too, because they have to worry about patient safety and what clinicians want, but it's all driven by insurance regulations, payment, charge capture. They just have to do so much. It's not like in any other industry.
A two-part question, but they're related. What about data from fitness trackers, which is well known to be sold? And is there any case law around that? And then the recent story about 23andMe wanting to sell genetic data and then backing off on that.
Right, so fitness trackers, yes, that's on my list too. I didn't include everything, but fitness trackers, the vendors get your information. If your employer gave you the fitness tracker, they might be getting the information. Again, the vendors claim that they are de-identifying the data, and that so no one will be able to recognize individuals, but they are not governed by HIPAA. And de-identification, I could do a whole lecture on that. What does de-identification mean? HIPAA is pretty strict. It lists 18 identifiers you have to remove. But if you're not a healthcare provider and you're not governed by HIPAA, you can just remove a little bit of information. And do you know, 80 to 90% of the population can be uniquely identified by 3 factors alone: birth date, sex, and zip code. If you've got those 3, birth date, sex, and zip code, you don't need names, you don't need social security number. Chances are you can identify the person. And so if you leave those 3 in, it's really a no-brainer. And so if people say, oh, it's de-identified, or the breast story I said, it didn't have in big letters who the person was, but you could very easily find it through a Google search. So de-identification can be of small comfort. And yeah, I mean, 23andMe and others, they talk about selling the data, then they get pushback. Consumers say, well, then we're not going to use your services. Ancestry.com, same thing. And so some of them back off, and some of them will continue because it's very lucrative. If you have a data broker that's willing to pay you tons of money, that is very, very tempting. And again, you can say, well, we'll de-identify. What does that mean? Okay. We're live streaming, so we do need you to speak into the microphone.
Okay, I will. Are you aware of any situations where the system of electronic health records has affected a hospital's rating by JCAHO, Joint Commission on Accreditation of Hospitals?
Yeah, I am not aware of any such story, but there may be some. Are you aware of anything?
No.
No, okay. There was a question back there.
I'd like to ask you about health insurance companies and their access to and use of medical records. Are there any limitations on the health insurer's ability to get information from the medical provider? Are they free to ask for anything they want and any degree of detail? And independently, the answer to that, what controls are there on the security of that information in the hands of the health insurer?
Okay, so health insurers can pretty much get any information they want. We all sign that form that tells the doctor, for billing purposes, do whatever you need to do. And HIPAA itself has an exception for healthcare treatment and operations. And so for healthcare operations, for billing purposes, they can share information. It would be very difficult if they had to get your permission repeatedly for every detail and so on. We do have the HIPAA security rule, which I didn't mention before, but the HIPAA security rule outlines different security measures that covered entities have to comply with. So there are physical, administrative, and technical safeguards. And I don't think it's good enough, but it's pretty detailed. And health insurers are covered entities, so they do have to comply with at least the HIPAA security rule. Okay. Anything else? I think I'm supposed to make 100% sure that we have 60 minutes here. I think we're close, but maybe one more question for CLE purposes. Okay.
So for my chart and the others, systems that are out there, firewalls are obsolete? Is that what I'm hearing?
Yeah, the technology is ever changing, so now they're using cloud storage and so on.
I was trying to get to how ransomware is stealing it.
Oh, well, so ransomware, the clever aspect of it is they didn't even have to steal it. All they had to do is encrypt it using technology. So they just locked it up. They didn't access it. They didn't read it necessarily. They locked it up. And then they said, if you want the key to unlock it, pay us big money.
But there couldn't have been a firewall if they were able to get in to lock it up. Would it be inside, or no, they could still get around it from the outside?
I think they were able to get around it at the outside, and then it turned out that the most vulnerable computers were ones that hadn't put in a particular update, which Microsoft had just released. And so if you had a system that wasn't automatically updating, that's how they got in. So you have to be up to the minute. Okay, thank you so much. Have a great day, and hope to see you at our April conference.